what's nice about this NovApproach implant is that I can really put it in from any angle. So I can put it in as a direct anterior with the patient in a supine position, but also I could use an oblique corridor. So I've got an oblique holder for it, and so I can really put it in from the lateral corridor, the anti-psoas corridor, or anteriorly. Because of the way the screws are designed, I can almost always get 4 screws in. So often when I put it in an ALIF, I can kind of get screws, maybe 2, maybe 3, but my anterior column support with screws is much more reliable with this variability in our approach. So I was just to take a few minutes and show some cases with my experience. I think I've done a total now of about 40 cases, maybe 80 levels or so on average.
Something like that, yeah.
Again, what's special about this implant is the ability for the implant to match multiple different trajectories. So whether you're coming from direct anterior or obliquely or laterally, we've got the ability to actually put the implant in using either a oblique insertion point or an anterior insertion point, and to put in our fixation screws reliably, and reliably get 4 points of fixation. The implant sizing is also interesting because I think so often when we think about how we ask for our implants in the operating room, we tend to say, well, 12 millimeters anterior height, 14 degrees. And to me that never makes sense. Really, I want to focus on a posterior height. What I'm trying to do is get some posterior inner body height. I'm trying to really optimize the indirect decompression. So my rule is generally I like to have a minimum of 7 millimeters, more often 8 millimeters of posterior height. And I'll actually work my release of that inner body space until I'm able to get that posterior base distraction. Oftentimes actually taking down the PLL in my ALIFs. But I really like to get at least 7 millimeters of inner body height. So these implants, you can still ask for them by lordosis and anterior height, but you can actually ask for them by posterior height as well. And that's what I tend to do, is I tend to ask for the posterior height, and I work my way up from 4 to 5 to 6 to 7 of posterior height, then I build in the lordosis. I think that really optimizes my indirect decompression. And then again, our screw trajectories allow you to get 4 screws in just about any level of the spine. Here's another case that I thought was an interesting one to show because of the advanced calcification of the vessels. So when you look pre-operatively, you can literally sort of see an angiogram. You can see the calcification of the aorta, the common aortic vein. And this is the case where I think a lot of people might say, I'd rather not do an anterior on this. The fragility, the potential of fracturing that atherosclerotic plaque is significant. So we want to minimize our retraction of vessels. And you see how the aorta comes right over the 4-5 level, and that bifurcation in this case was really relatively low. So minimizing retraction of vessels is a big part of, I think, safety in spine surgery, especially in some of these older patients. So in this case, I just did a L4 to S1 as a patient who had, again, a post-laminectomy deformity with persistence of radicular pain, a lot of collapse at 4-5, foraminal narrowing at 4-5 and 5-1. So again, using a slightly more oblique approach, I was able to minimize my retraction at 4-5 with those atherosclerotic vessels and come in an anti-psoas approach with the patient supine. You see how nicely we were able to really open up that posterior height at 4-5 and 5-1. So restoring that posterior height. In general, I get at least a 7 or 8 millimeters of posterior height to get that indirect reduction of the foramen. And again, at 5-1, I put my screws down into the sacrum, 4-5 up in L4, and then I'm able to get some rotational correction with the vasectomies in the back by not locking those cages in. It was very easy without retracting the vessels for me to get these cages right onto the midline. And again, that's, I think, testimony to the fact that these cages can be inserted at 5-1. I'm usually inserting the cage. More as a direct anterior, and at 4-5, that oblique insertion can be really quite useful. And again, this is done with really relatively minimal retraction of the vessels. A brief overview of some of my experience with this NovApproach OneLIF cage.